When we speak about post-cardiac arrest, it is a syndrome. It is due to stopping of the heart pump due to many causes. Post-myocardial arrest, it is a syndrome composed of triad, that is brain anoxia and myocardial dysfunction and reperfusion syndrome. This post-cardiac arrest syndrome causes by reversible and non-reversible cause. Let us focus about reversible cause, which is known as 4H and 4Ts. The 4H is hypotension or hypovolemia, and hypokalemia or hyperkalemia, and hypoxia, and hypothermia. This is the 4H. The 4T cardiac tamponade and toxins and tension pneumothorax and thromboembolic disease, which is myocardial infarction and pulmonary embolism or any embolism. The most important thing in post-cardiac arrest syndrome is to management. So any post-cardiac arrest, either in hospital or out hospital, this cardiac arrest exceeds the 5 minutes, you have to secure the airway by intubation. So endotracheal intubation and connection to mechanical ventilation is mandatory. This is the first point in post-cardiac arrest management strategy. So if any post-cardiac arrest more than 5 minutes, you have to intubate the patient immediately. The second, you have to sedate the patient. Full sedation is mandatory until RAS minus 3 at least, or the target is RAS minus 5. Sedation is important, especially for the next 24 hours. Old reference was 72 hours, but the recently better to be 24 hours to decrease the brain metabolic rate. You have to keep mean arterial pressure above 80 millimeter mercury to maintain the cerebral perfusion pressure above 60 millimeter mercury, and therefore maintaining at the same time oxygenation of the brain. Also keeping the MAP above 80 help in maintaining perfusion to myocardium itself and other tissues. So to maintain the MAP above 80, you have first to give a bolus of fluid, 500 ml of saline. If the pressure, mean arterial pressure, not reach 80 millimeter mercury, you have to introduce inotrope. Also, during this 24 hours of sedation, oxygen saturation should be kept between 92 to 98 at least to ensure that oxygenation is perfect by ABG to see the partial pressure of oxygen above 75 millimeter mercury. Also, carbon dioxide should be kept between 35 to 40 millimeter mercury during the first 24 hours to avoid cerebral edema and cerebral complication of hypercapnia. I think better to be monitored by capnography during the course of first 24 hours is more beneficial than using serial ABG. Blood glucose should be also kept between 140 over up to 180 milligram per deciliter within first 24 hours, according to the national sugar trial. This is associated with less mortality and good outcome. For the first 24 hours, either in hospital cardiac arrest or out hospital cardiac arrest, you have to avoid high temperature. because high temperature, as you know, lead to increased metabolic rate and therefore more complication on the brain and consuming the oxygen. So avoid hyperthermia at all time post cardiac arrest, especially for the first 24 hours. So the aim is to keep the temperature between 35 up to 37 centigrade. Some studies suggest that out hospital post cardiac arrest you have to apply hypothermia, but it is not associated with good mortality benefit. It's just aim to gain time and decreasing metabolic rate for the patient. So the target is 33 to 36 centigrade for the first 24 hours. And next day you have to start rewarming the patient every hour by rate of 0.5 centigrade. Seizure prophylaxis in the first 24 hours also is mandatory, especially if patient out hospital cardiac arrest, to decrease cerebral complication. Finally, you have to identify the cause of cardiac arrest, especially reversible cause should be treated immediately. One of the commonest cause of cardiac arrest is electrolyte disturbance and acid-base disturbance. So you have to take a blood sample immediately and send for lab investigation for electrolyte, especially potassium, and arterial blood gases, and toxicology screening. So also don't forget to do X-ray to exclude any tension pneumothorax, or bedside ultrasound. I think is more specific than X-ray, and bedside ECG to see any arrhythmia post cardiac arrest, and also is very mandatory to do echocardiography to exclude myocardial dysfunction post cardiac arrest, because myocardial perfusion will be affected, and therefore some sort of myocardium hypokinesia should be excluded by echo. About factor associated with poor outcome after retaining of spontaneous circulation, there is general and specific factors. Let us start with general factor affecting the outcome post cardiac arrest. The most common is unwitnessed arrest with no bystander cardiopulmonary resuscitation. This is the most thing, because if there is no immediately cardiopulmonary resuscitation, this will affect the outcome. The second thing is if patient come with asystole or pulseless electrical activity, this will affect the outcome also. Also, applying basic life support more than 10 minutes prior to advanced life support, this will affect outcome. Or advanced life support take more than 20 minutes to do it before return of spontaneous circulation. The specific factor associated with poor outcome post 72 hours of return of spontaneous circulation, the most common is absence of bilateral pupil reflex, and this is specifically in the first 24 hours. After 24 hours, if there is no bilateral pupil reflex, is associated with poor outcome in post cardiac arrest. Also absent bilateral corneal reflex after 24 hours, indicating poor post cardiac outcome. The motor part of the Glasgow Coma scale is very important after 72 hours of return of spontaneous circulation. So after 72 hours, if the motor part degree is less 2 or less, this indicating poor outcome. Also, any seizure, either status epilepticus, myoclonic status epilepticus, or absent seizure appear on the monitor, like hypoxia, tachypnea, and unstable blood pressure. All these parameters indicate there is a seizure post 72 hours of return of spontaneous circulation. So you have to avoid any evidence of seizure after 72 hours using continuous electroencephalogram. So it's mandatory to monitor the electrical activity of the brain post 72 hours to exclude any seizure, because it's associated with poor outcome. Brain biomarker also in some specific center it is available. Brain biomarkers such as neuron specific enolase, if it is increased more than 33 milligram per deciliter, indicate poor outcome. This is after 72 hours of return of spontaneous circulation. So one of the predicting test is brain biomarker, which is a neuron specific enolase. Also bedside somatosensory evoked potential. If absence, it indicates poor outcome. But this test is not available in most centers here in Sudan. Electrocardiogram is very important. So continuous EEG is important during the 24 hours course of post-cardiac arrest. Also after 72 hours, if do EEG and you find that there is no electrical activity or there is a burst suppression, this indicates poor outcome. But before doing this, you have to exclude that the effect of circulating sedating drugs have been excluded. So you have to take sample to see the sedative drug level in circulating blood. Thank you for listening and watching this video. I hope it is useful for all medical student and all colleague in critical care and doctor in critical care specialty.